Good evening and welcome to Doctors on Call. I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth. I'm your host for tonight's program on women's health. We'll be taking your questions about menopause, hormone replacement therapy, osteoporosis, and cancer in women, and we'll be happy to discuss any other concerns you might have about women's health. Please remember the show is about getting your questions answered, so call the telephone numbers on the bottom of the screen. Locally, dial 218-788-2844 or call toll-free at 1-877-307-8762. I'm pleased to welcome our panelists this evening, Dr. Colleen Evans, an OB-GYN specialist with Essentia Health-Duluth Clinic, Dr. Joleen Finken, an internal medicine specialist with St. Luke's Internal Medicine Associates, and Dr. Melissa Miller, an OB-GYN specialist with St. Luke's Obstetrics and Gynecology Associates. Our medical student volunteers answering the phones tonight are Mindy Cabal Anderson from Wilmer, Minnesota, Jeffrey Rosso from St. Peter, Minnesota, and Taryn Reishan from Crabtree, Oregon. And now on to tonight's program on women's health. So usually a couple minutes before the questions start, but maybe we should talk about pap smears since we do have some of the criteria that have changed a little bit. And Dr. Miller, do you want to kind of lead off and tell us what are the criteria for when you should have a pap smear?
Yep, sure. We start pap smear screening now at the age of 21 and recommend pap smears every 3 years if they're normal from the age of 21 to 30. We've also added an additional test starting at about the age of 30, which is HPV testing with pap smear. If the HPV is negative, it's every 5 years, as well as a normal pap smear until the age of 65 or 70, at which time we stop pap smear screening. I wanted to talk a little bit about HPV. HPV is the human papilloma virus. It's a virus that is sexually transmitted but very common. About 80% of women are exposed to the virus at some time in their life if they are sexually active. And it is the virus that can cause vulvar warts as well as cervical cancer as well as some other cancers. And that's why combining pap smear screening with the HPV virus helps us detect better who's at risk for cervical cancer, because pap smear screening is a screening test for cervical cancer.
Oh, that's very helpful. So Dr. Finken, when a woman comes to the like a yearly physical, what are some of the things that we should have done? Let's say you're over 50.
Okay, so if you're over 50, you definitely want to make sure that you get a colonoscopy to screen for colon cancer. And the primary care, either family medicine or internal medicine, can also do the pap smear and the pelvic and the breast exam. And then start talking about mammograms. And generally, I do recommend those still every year after the age of 50, although there's some controversy about that. Screening for osteoporosis, that has changed a bit in recent years. We used to start that much earlier, but now the official age is 65, unless there are additional risk factors like smoking or certain medications, which could put you at higher risk of osteoporosis. Immunizations, a pneumonia shot at the age of 65, the shingles vaccine, Zostavax, we're recommending that at age 60. And then one of the changes in immunization is regarding the tetanus, which we still recommend every 10 years, but pertussis has been added to the tetanus, and so you should have that updated as well. You know, especially if you have grandkids, because the pertussis, the whooping cough, can be quite lethal to the younger kids. It makes adults miserable for 6 to 12 weeks, but it can really be life-threatening for them. And then risk factors for heart disease and stroke, the cholesterol panels, exercise, body weight, all sorts of things to reduce your risk as we go into our 5th and 6th and 7th decades. So there's a lot to cover. And so that's a bit of a challenge, because people still come in thinking my yearly physical is the time to discuss my 10 concerns, but there's a lot of work to be done for health maintenance and screening and prevention of heart disease and stroke and cancers. So sometimes a couple of visits are required to make sure you're getting all your needs met.
And a lot of preventative health issues as well, too.
Right, right.
So if a woman is having abnormal bleeding, what are our concerns, Dr. Evans?
Yeah, so in a patient who is, or a woman who's stopped having her period for more than 12 months, she's then considered to be menopausal. And any bleeding after that time is cancer until proven otherwise. So it's really important to go in, talk to your doctor about it, and then at that point in time, they'll likely recommend a biopsy to make sure that it's not a cancerous process going on.
Well, the questions are starting to come in, so let me just review a couple of them here. I have a Dr. Miller, a 62-year-old female who had a hysterectomy and ovaries removed as well, was on hormone replacement therapy, but a continuing problem with having hot flashes, which we probably hear a lot about. Any recommendations for recurrent hot flashes?
Sure. Hot flashes occur obviously around the time of menopause. For some women, hot flashes last a couple years, but for other women, they may be lifelong. And the current recommendation for hormone replacement therapy is therapy for women who are experiencing hot flashes or other symptoms related to menopause. And even though she has been on hormones in the past, her doctor may revisit placing her on hormones again if she feels the hot flashes are interfering with the quality of her life. And that's something she should discuss with her primary care physician or gynecologist.
Yeah, that's great. Dr. Evans, too, a woman who's had breast cancer and then might not want to be on hormone replacement therapy. Any other suggestions for hot flashes?
Yeah, there are non-hormonal preparations and medications that can be used for managing hot flashes. One of the medications, brand names, is called Effexor. It's most commonly used for depression and anxiety, but has also on lower doses been helpful for management of hot flashes. There are also a couple other less known medications, one of which would be called Klonopin, that can be used at lower doses, which can be helpful in management of hot flashes if hormones aren't an option for that patient.
Yeah, I know it's often a concern for women. Difficulty sleeping probably as well, too. Well, Dr. Finken, a caller is asking about lap band surgery for women, for women's health. Any recommendations of when that would be a consideration?
There are official criteria over which insurance will cover that procedure. A body mass index of 35 or above, which takes your height and weight into consideration. It's a calculation, but your doctor can provide that. And then you'd have to have associated comorbidities like sleep apnea or diabetes. If you don't have any other of these comorbidities, then a BMI over 40. So it's hard to give just a pound, like over a certain weight. It depends on your height and weight. And it's quite a complicated process. Usually by the time you actually get the surgery, you've spent about a year going through the psychiatric evaluation and the medical evaluation to make sure you're an appropriate candidate. So it's not one size fits all. Every patient is different, and it can be very useful. It can reverse diabetes completely, but it's definitely something that comes at the end of many other interventions, you know, whether it be Weight Watchers, bariatric medicine, which is non-surgical, just that's mostly counseling and dietary advisement. Psychologists, you know, there's a lot that goes into obesity, which has now been classified as a disease in itself, you know, over the last year. So you really need to talk to your doctor about that because there's a lot of variables as to who should have the lap band and when.
Different options for people. So Dr. Miller, asking about urinary incontinence and kind of dribbling that occurs when people cough or sneeze, especially women. How is the workup completed for that?
Mm-hmm. There are different types of incontinence. The two most common types are the genuine stress urinary incontinence, which you just asked about, and that's coughing or leaking of urine with coughing, exercise, activities. And then there's the urge incontinence, which is leaking of urine with a bladder spasm, and then there's some other types of incontinence. With stress incontinence, there is a workup to make sure that it is actually incontinence which is occurring with activity. It does include like a urine analysis to make sure there's not an infection. And then there's a couple different treatments, but the two treatments that work the best are either a pessary, which is a device that can be inserted inside the vagina to kind of put pressure on the urethra so with coughing and sneezing there isn't leaking of urine, as well as an outpatient surgery procedure, which can be as high as 85% effective at stopping the incontinence. And it's outpatient, works very well. So if somebody does have that issue, I would highly recommend seeing a gynecologist or urologist because it is correctable and it can really help with the quality of a woman's life.
Dr. Evans, a caller from Duluth asking about cancer screening for ovarian cancer. So if a woman has had a hysterectomy but still retains her ovaries, is there a screening test or anything that can be done to evaluate the ovaries?
Sure, that's a good question. You know, there is no specific screening test for ovarian cancer. In a patient who has had a hysterectomy, it is appropriate to go in for yearly pelvic exams. That really and truly is the only way your gynecologist will feel for internally for the ovaries and fallopian tubes to make sure that it doesn't feel like there are any masses present. There has been discussion about doing screening testing with a CA-125 blood test. That is not a good screening test. There are lots of false negatives, and it leads to lots of extra interventions, CT scans, ultrasounds, extra visits, and a lot of worry as well. It's not really a helpful screening test.
What do you tell patients who come to you and ask if they can have an ultrasound because they're worried because their aunt has had ovarian cancer or a friend of theirs has had ovarian cancer?
Sure.
What do you tell those patients?
Yeah, that definitely happens. You know, ultrasounds have a really good ability to see the ovaries and gynecologic organs. But again, it's not a good screening tool for ovarian cancer. Unfortunately, the majority of patients who are diagnosed with ovarian cancer are diagnosed at stage 3 or stage 4, which are end stages. There have been multiple studies done to see if there is something that can be done as far as CA-125 tumor marker and ultrasound screening, and nothing has panned out, and it just ends up resulting in increased testing and increased surgeries that aren't necessary. What I would recommend is having the patient go through and get a very thorough family history, understand who had ovarian cancer at what age, how were they related, and then potentially talking about seeing a genetic counselor to see if they are an appropriate patient for genetic testing, which would put that at increased risk for ovarian cancer.
Helpful, very helpful. Dr. Finken, a caller asking about Zostavax or shingles vaccine. And do you need more than one? And maybe just talk about Zostavax a little bit too.
Okay, the shingles vaccination is indicated after age 60, and right now there's no recommendation for a booster. Now, one of the 3 bodies of people who recommend vaccinations, one of the 3 have said you can start at age 50, but the general consensus is that you should wait till you're 60 because there isn't a booster, and as your immune system weakens as you get older, that's when you're more likely to get shingles, and that's when you want to have the antibody response still viable to cover you. So another question I get a lot is, I've already had shingles, should I get the shingles vaccine? And it is indicated, I mean, it is recommended because you can get recurrent cases of shingles. It will reduce your chance of getting shingles by 50%, according to the statistics. But if you've had the shingles vaccination, your chances of having the post-herpetic neuropathy is decreased. So the big thing with that vaccination is you want to check with your insurance because a lot of insurances cover it, but some don't. And if it is not covered by your insurance, you can get it at Walgreens, and it's cheaper there than in most clinics because of overhead costs. But I do recommend it. It's been around long enough where I have not seen people get the shingles. It is a live vaccine, so you don't want to give it to somebody who's on chronic immunosuppression because they could get the shingles from the shot. But I feel comfortable enough. I've given it to enough people, and it's been around long enough where we haven't seen people actually get the shingles from the shot. So age 60, I do recommend it.
Excellent, good. Dr. Miller, a caller from Superior asking about heavy clots with menses, lasting several days, and what kind of workup should be done regarding that? We used to use a term called DNC. Maybe you can talk a little bit about that as well.
I call it abnormal uterine bleeding, which is very common amongst many women. The workup is somewhat extensive as we want to know why the bleeding is occurring. And if the bleeding is irregular, oftentimes we'll check the thyroid gland to make sure that's working well and that isn't contributing to it. We also oftentimes will do an ultrasound to make sure there aren't fibroids, which are non-cancerous smooth muscle tumors, or adenomyosis, which is endometrial glands growing into the uterine wall, or other reasons. Sometimes even pregnancy will cause abnormal bleeding. So there is quite the workup. We also want to make sure that you don't have endometrial cancer. So oftentimes your doctor will do an endometrial biopsy to make sure there isn't precancerous cells or cancer, because one of the first signs of endometrial cancer is abnormal bleeding. But so there is a workup involved. However, there are many, many different treatments for heavy uterine bleeding, which can involve as simple as a medication that's taken only at the time of your menstrual period, to birth control pills that are taken daily, to a procedure where we just freeze or cauterize the lining of your uterus, which can be done either in the office or in the operating room, to hysterectomies, which oftentimes can be done laparoscopically now. And sometimes even after a hysterectomy, people go home the same day. So there's many treatments. So if you're suffering from heavy bleeding or irregular bleeding, I think it's really important to see your doctor and get treatment.
Probably check a hemoglobin.
Oh, sure. Of course, check a hemoglobin to make sure that you're not terribly anemic from bleeding too heavily, which can cause people to feel tired, weak, dizzy. So that would be part of the workup too.
Okay. Dr. Evans, just a reinforcement about the pap smear. There's a caller asking about that the patient doesn't need to have a pap smear more often than every 5 years. I think we should probably just review that again about the pap
Sure.
smears.
Something that would make you want to have a pap smear or have it recommended that you have a pap smear more than every 5 years would be if you have a history of abnormal pap smears in the past, where you've had surgery done to your cervix to remove a piece for a biopsy. If you have a new sexual partner, that would be a reason to have a pap smear, because you can be exposed to a different type of HPV virus. Some patients who have chronic medical problems where they're on medications that suppress their immune system, they might need pap smears more often as well.
I think it's really important to point out that when I talked about the guidelines for pap smear screening, that is for people who are getting regular screening. And when I diagnose cervical cancer, oftentimes it's women who had a baby and they've gone many years without pap smear screening. And it's very important to know that cervical cancer is very preventable if people are getting their pap smears. So, and this current recommendations came out very recently. So even if somebody's had a pap smear last year, I'd still recommend yearly exams, because there's more to a yearly exam than just pap smear screening, but also the discussion with that physician regarding whether or not they need a pap smear this year or not. That is a new recommendation, and it goes along with the HPV screening. So we can't just blanket everyone every 5 years.
Absolutely.
So
It takes us a while to change too.
It
To
does.
make sure that we're trusting the changes. Dr. Finken asking, now we're going to change topics a little bit here, to statins and leg cramping with statins for elevated cholesterol. Anything you can do about those? Is it related to the medication?
Yeah, that's the hardest part about statins. They are the best medication for lipid lowering, and they have the outcomes data. I mean, it does reduce recurrent events, either heart attacks or strokes. I mean, it is the best medication, but it does have the side effects that people will notice the most, and that is muscle aches and muscle cramping. So one approach is to switch to a different statin, and sometimes if you switch to a different statin, you won't have the problem. If you switch to a stronger statin, you will be able to take a lower dose, so have fewer side effects. Coenzyme Q10 has been found if you take that with the statin to reduce those muscle aches and cramping. Sometimes taking a statin every other day, you'll still get the benefits, but you won't have the side effects. So it is a problem. It's a great drug, but there's also a lot of patients who can't tolerate it.
Excellent. Dr. Evans, talk a little bit about vaginal cancer and how we would potentially pick that up.
Sure. Vaginal cancer is very rare. It is caused by the human papillomavirus the majority of the time, like Dr. Miller talked about earlier. And it's the same sort of way that cervix cancer happens, where the HPV virus infects the tissue and then is able to replicate and cause abnormal changes in those cells. And instead of happening on the cervix, it happens on the vagina. It can also happen on the vulva as well. Not all vulvar cancer is caused by human papillomavirus. There are other precancerous skin changes there, but yeah, vaginal cancer is very rare, and the pap smear would potentially pick that up as well, just like it would pick it up on the cervix.
And during exams, during the vaginal exams?
Yeah, during exams, if there's a mass found in the vagina, that would be biopsied, and if found to be cancerous. The vagina also goes through the precancer changes that the cervix goes through, so it's important that if there's an abnormality that it gets checked out.
Dr. Miller, just the NovaSure cauterization, primarily for abnormal bleeding. We talk about that a little bit. There are some questions
Sure.
about that.
When I talked about abnormal uterine bleeding and the different treatments, one of the treatments is destruction of the cavity of the uterus, and that can be done through freezing, through like the cryoablation, or NovaSure, where we actually put an instrument in and cauterize. And the idea is to destroy the active endometrium so that people have lighter periods. Very uncommonly will people get no period at all, but the idea is just to have lighter periods. It's very effective in a lot of women, but they have to meet certain criteria. For instance, they shouldn't have very large uteruses, they shouldn't have fibroids that would be contributing. They need to be biopsied to make sure they don't have any precancerous endometrial or uterine cancer lesions or cancerous lesions. And also it's very important that in women that get a treatment like NovaSure or her option, which is the cryotherapy, that they do not want any more children, because when we're destroying the lining of the uterus, that is where a pregnancy is implanted. So it's very important that that person has a very effective form of contraception to prevent pregnancy.
Helpful. Dr. Finken, bone scan, let's again switch topics a little bit. How often should a woman have a bone scan for osteoporosis?
Yeah, and that's another thing that's been in flux in recent years. So the official time that we start is 65, and when our endocrinologists or rheumatologists interpret them, a lot of times they'll say follow up in 2 to 3 years, but we are starting to see that we probably can be doing those a lot less often. So if you have mild osteopenia, they say even every 5 years. So it's a kind of a moving target. It depends on your risk factors, and so you need to sort of personalize that with each patient.
And Dr. Evans, just talk a little bit about hormone replacement therapy. We only have about a minute or two here left. So I have a caller asking about, after having a hysterectomy, is it okay to still stay on estrogens for hot flashes or
Yeah,
symptoms?
so hormone replacement therapy, if you don't have a uterus, using just plain estrogen is fine. If there's a uterus in place, you should use estrogen and progesterone at the same time, because if you use just estrogen, it puts you at risk for developing endometrial cancer. Otherwise, Dr. Miller, you might have a couple more.
How long should a woman
Yeah,
stay
how long?
On hormone replacement therapy. Well, we recommend the least amount of time with the lowest dose. We usually recommend starting it right around the time of menopause, and for 5 years or less, and that's based on studies that looked at the risk of breast cancer with hormone replacement therapy. Now, the literature is very conflicting regarding the risk of breast cancer. The WHI study, which is the most well-known study, looked at the risk of breast cancer was increased with estrogen and progesterone, but actually the risk of breast cancer was decreased with estrogen alone. So again, this is a very important to discuss thoroughly with your physician to decide whether or not hormone replacement therapy is appropriate for you.
Yeah. Any other comments about that?
Well, just the timing too. We try to get women off by their 6th decade. By the time they're 60, the time when heart attack and stroke rates go up, we really try to get people off the hormones.
But like I said, some people have hot flashes, so they do stay on it forever because they do have trouble sleeping and they're very uncomfortable.
Yeah.
So again, it's always personalized. The other thing I want to say quickly before the show is done, that we oftentimes use vaginal estrogen, and that's very different than the systemic or the oral estrogen or the patches. and that's to help with people so they don't have changes in their vagina that cause burning and itching and difficulty with pain having intercourse.
With dryness. Well,
so
thank
that's
you.
different.
Thank you very much. I want to thank our panelists, Dr. Colleen Evans, Dr. Joleen Finken, and Dr. Melissa Miller, and our medical student volunteers, Mindy Cavall Anderson, Jeff Russo, and Taryn Ration. Please join Dr. Ray Christensen next week for a program on men's health, when his panelists will be Dr. Gail Baldwin, Dr. Jake Powell, and Dr. Paul Tonkin. Thank you for watching. Good night.